Good evening, everyone, and welcome to our Iridex webinar. Tonight, we're going to talk about using the MicroPulse technology in the treatment of glaucoma. I'm very happy to moderate this session with such a great panel of speakers from the Middle East and North Africa, and I'm sure that we're going to learn a lot of things about MicroPulse tonight. So I will start by sharing my screen. So I'm going to give a quick introduction to MicroPulse technology. Those are my financial disclosures. So as you know, when it comes to glaucoma treatment, the goal of glaucoma therapy is not a number. It's not about the intraocular pressure, but it's about preserving the quality of life and the quality of vision of your patient. And this is why many developments in the field of glaucoma care lately have been focusing not only on efficacy, but also on the safety of treatment. If you take, for example, the field of glaucoma surgery, migs have become such a hot topic. Everyone's talking about it with all those devices focusing on safety. And this safety revolution is also taking place in the field of glaucoma laser, especially with the introduction of MicroPulse lasers in 2015 when it got FDA approved. So what is a MicroPulse laser? Basically what they did is that they took the classical continuous wave diode laser and turned it into a MicroPulse. When you're using a classical diode, a continuous wave diode, when you shoot the laser, when you put your foot on the pedal, the laser is on in continuous mode. But this is not the case with a MicroPulse laser. It goes on and off, on and off. So you have less heat dissipation, less tissue damage, and theoretically less inflammation and less complication. And Robert Neuker proved that by treating human cadaveric eyes, either with a MicroPulse laser or with a continuous wave laser. As you can see here, the eyes that were treated with a classical diode have extensive coagulative necrosis, extensive tissue damage, but this was not the case of the eyes treated with a MicroPulse laser. So how does this technology work? As we all know, cyclophotocoagulation works by decreasing the inflow, but studies have also proven that it increases uveoscleral outflow by increasing the permeability of the ciliary body. And recent works on MicroPulse technology at the University of Washington has also suggested that MicroPulse might increase the trabecular outflow by contracting the ciliary body fibers, opening up Schlemm's canal, just like a drop of pilocarpine would do. So what about the treatment technique? It's non-invasive, it's quite simple, and the learning curve is quite straightforward. You just use a MicroPulse probe, the MP3 probe, to paint the limbus back and forth. The learning curve is quite easy, and you need to use a coupling agent like viscoelastic or lidocaine jelly to improve the absorption of laser energy at the level of the tissue. And the amount of pressure that you put here is comparable to holding a pen and writing on a piece of paper. When it comes to the parameters, the duty cycle is more or less fixed by the machine, so you need to set up the power of your laser and the duration of the treatment. The recommended parameters of Iridex are 2000 milliwatts when it comes to the laser power and 80 seconds per hemisphere. So you do 80 seconds superiorly and 80 seconds inferiorly for the treatment. This is the MP3 probe. So it has a curved anterior edge and a flat posterior edge. And you can see here the laser, the fiber protrusion at the level of the tip of the probe. And they recently introduced the Rev2, their generation 2 probe. You can see here it has a scleral matching curvature that allows you to be flush with the tissue. They also got rid of the protrusion, and you have instead a recess that allows better coupling and better delivery of the energy to the tissues. And interiorly, you have those rabbit ears and a curvature that matches the profile of the limbus. Another cool feature of this generation 2 probe is that it has a very thin stem, and it makes treatment even more easier with this new generation. So back when I first started to be interested in the MicroPulse technology back in 2016, we only had a couple of peer-reviewed papers out there in the literature, mainly from the US and Singapore. And then the interest for this technology started to grow exponentially. And if you look at it now in 2020, you have a lot of peer-reviewed paper coming from all over the place. But I'm going to focus on the papers coming from our region, from the Middle East and North Africa. The first paper to be published was in 2018 by Yasmin Sayed and Ahmed AlHabash in the Journal of Glaucoma. They are from the University of Cairo. Basically what they did is that they compared the classical diode to the MicroPulse laser in a pediatric population. And their conclusions in a nutshell are that both technologies are comparable in terms of IOP reduction, but the MicroPulse was safer. You had less complication, less pain, less inflammation, and a mean duration of success that was longer with MicroPulse. And then in 2019, we published our paper in Beirut, also in the Journal of Glaucoma. We treated 75 eyes with a standardized protocol of MicroPulse. The average baseline IOP was 26 millimeters of mercury. And at 15 months, it decreased to 15 millimeters of mercury with a good safety profile. And last but not least, the paper that was published in Clinical Ophthalmology recently by our friend here, Ahmed AlHabash from Saudi Arabia. He treated 71 eyes with a standardized MicroPulse protocol. The average baseline IOP was 35 millimeters of mercury, and at the last follow-up, the average IOP was 16. So those are rather impressive results. So in summary, those papers show an IOP reduction that is somewhere between 35 and 60%, and all those teams reported success rate that were above 70%. So in conclusion, this is a technology that has a good safety and efficacy profile, and it seems to be efficient in our patient population here in the Middle East and North Africa, according to the literature. There's definitely a growing interest out there, not only internationally, but regionally. And I can't wait to see what our speakers are gonna say about it tonight. So without further ado, while Dr. Ahmed Abdelmajid is gonna share his screen, I'm gonna introduce our first speaker tonight. This is Dr. Ahmed Abdelmajid. He's a glaucoma consultant at Ain Shams University in Cairo, Egypt. He's also a fellow of the Royal College of Surgeons in Edinburgh. Dr. Abdelmajid is a fellow of the Egyptian Glaucoma Society and the Egyptian Ophthalmological Society. He's gonna talk about a MicroPulse TLT, patient selection and cases examples.
Good evening, everybody. I have the pleasure to share with you my experience since I started to use the MicroPulse TLT since 2017. And the most important thing that was attracting me as a surgeon, of course, as Dr. Ziad highlighted, is the safety of this technique. We all know that the glaucoma treatment for decades, where we had a gap between using the drugs or the eye drops, as many patients and doctors likes to be safe. You know, we all know that the glaucoma surgical intervention is not simple, and requires post-operative follow-up a long period and a lot of complications, and may be severe enough to the patient may lose vision. And this gap, so the surgeons may be using multiple techniques and different techniques with different results, so that you have to go to either side, either to the safety with less efficacy, as we know with the eye drops, and with time there is a lot of systemic and local complication, as we know from the eye drops. At that point, you don't have much option before the introduction of MicroPulse TLT. You have to go to the surgical intervention in order to halt the progress of glaucoma, owing to have efficacy, but we know that all surgical intervention had many complications. So patients uncontrolled with medical treatment now have the chance to use a safer and, as we know from previous study, efficacious treatment at the same time before we go to surgical intervention, and may not also need to go for such surgical intervention in some patients. So we have many advantages for MicroPulse TLT. It's an FDA-approved device since 2015. We have evidence from many studies worldwide about the safety and efficacy of the technique. And we also have, all of us have to share our personal experience. Regarding the safety and efficacy was proven in most of the studies. Another point is the versatility, so that you can use the technique either before or after surgical intervention, and the parameters are titratable. You can customize your treatment according the condition of the patient, as we will see. Also, one of the most important issues is the repeatability. We know that most surgical interventions, if you do it once, the second surgical intervention will be more challenging. But owing to safety and efficacy of the technique, it is easily repeatable, and the results are additive, I think. Last thing is the durability, and most of the study we have studied that showed that the IOP reduction lasted for nearly 72 months. We have IOP reduction for such a long period. So, in talking to our patients, who will benefit from such a technique? As we can see, the MicroPulse can be, you can put it before or after any options of the medical treatment modalities you have. It can be used prior to surgical intervention in conjunction with any of the available surgical intervention, and of course following of any surgical intervention. Also, we can replace, it can be replacing some of the surgical intervention in special situation. As we know, some patients taking medication for a long time may have some mental or physical compromise to use the eye drops, and at the same time, they refuse to do surgery, either due to their general situation or other factors. Also, for the female patient, female glaucomatous patient in the period, in her childbearing period or a lactating female, we all know that the eye drops all classified as very to be harmful during pregnancy and lactation. So we have this option either to be done before the planning for pregnancy or even after pregnancy to control the IOP, but prefer to be done, of course, after the first trimester. I will present two of my cases. The first one is a patient, 60-year-old female with bilateral primary open angle glaucoma. Her IOP was 25 with 4 drugs. She's hypertensive cardiac. She had cardiac stenting before, and she's going on blood thinner. We all know that the use of blood thinner may be one of the side effects that we don't like to meet during incisional surgery. Her best corrected vision was 0.4. She is pseudophakic. She has a toxic keratopsy and she is complaining of persistent photophobia from the prolonged use of drug. Her field and OCT showed a moderate glaucoma damage. And of course, in most of my patients, I like to do a macular scan to be sure we don't have a macular edema, especially in diabetic patients. Her cup disc ratio was 0.5, and her left eye had old central retinal vein occlusion with PL vision. So in such situation, she cannot use the eye drops no more, and the process of laser trabeculoplasty may be used in earlier stage than this, and most of the traditional surgery we have problems due to long use of eye drops. We know we have postoperative severe conjunctival scarring, which is against the success of incisional surgery. Also, migs is not free of complications. We may have a lot of bleeding because she's going on blood thinner, as we know. So I decided to do for her a MicroPulse TLT session. I prefer to do the MicroPulse TLT in the OR. I know that some of the colleagues can do it in the office, but I prefer the OR as long as the patient will take a periocular or a peribulbar sedation, because we all know that the technique is painful and requires periocular or peribulbar or retrobulbar. And I like to do the peribulbar technique with some sedation. I don't like to use the speculum. I feel free to move my probe without the use of speculum. The speculum may sometimes halt the progression of the probe. I use a coupling media of xylocaine gel. In such a patient, I used the parameters of 2000 milliwatt and 100 seconds per hemisphere, so that a total of 200 seconds, and I do 10 passes per hemisphere. Each is about 10 seconds. So my pass will take 10 seconds and during the whole period. Of course, I spare the 3 and 9 o'clock position to avoid some of the complications that we are going to see. And by the end, I to use this curve that we see to get the best of all, to get a balance between safety and efficacy. If you look at the curve, at the green area, I always say stay in the green zone so that you get the most beneficial effect of treatment. And this is, as you see, after many studies have been done, we have lastly this very important curve, so that I always like to stay in the green area. In patients with bad situation regarding the optic nerve and the control of IOP, I would like to use higher energy, but I don't go in the red area because if you use red, you get more complications. So while using the laser, you have to customize your treatment according to the situation. Of course, patients with fair iris color may need, because they have less pigments relatively, so you may need to use more energy to treat such patients. Also, patients with high IOP, I like to go for the zone between the red and green area, and also the glaucoma severity and visual acuity. For patients with very good visual acuity, I like to go to the left side of the curve and to stay in the green area, not bypassing a total energy of 112 joules. Postoperatively, I give the patient non-steroidal anti-inflammatory eye drops, and I like to stop immediately the eye drop, because in my experience, most of my patients, I had tension below 10 if they go and continue on their medical treatment. So I like to stop it so that I can monitor the effect of treatment in such a situation. But sometimes you can use the eye drops until you get the maximum effect of treatment. Post-operative, the patient tension was 11 millimeter mercury without anti-glaucoma treatment, and within 1 week it was 13, and by the end of the 5th month, the tension was 16 millimeter mercury. And as the patient is a monocular patient, I need to keep the tension near the low teens, so I added only 1 eye drops to the patient, and the patient was not complaining at all to use only 1 eye drop. And now, after 6 months of follow-up, the tension is 13 millimeter mercury. What about the complication? There is no intervention without complication. But complication in such situation was very mild and tolerable by the patient, and the patient experience about the procedure was very amazing, so that she decided to do the other eye to get rid of her eye drops. A mild conjunctival hyperemia that disappeared completely within 1 week, no more than +2 flareant cells, and with only non-steroidal anti-inflammatories. I don't like to use steroid except if I am obliged to do so in severe inflammation, because I am afraid of IOP spikes due to use of steroids. One of the very important issues is some patient may get some pupillary mydriasis, and for sure this complication disappears completely. All the studies that were done, they reported that the mydriasis completely disappeared within 6 to 8 weeks after the treatment.
Ahmed, I'm afraid that we'll have to take only one case. Okay. We're already running late. Thank you for this interesting. Thank you for this very interesting case. And
Okay.
I'm going to ask Dr. Ahmed AlHabash to share his screen while I'm going to introduce our second speaker. Dr. AlHabash is an assistant professor at the Imam Abdurrahman bin Faisal University in Dammam. He's a glaucoma and cataract consultant there. He's also the ophthalmology residency program director at the King Fahd Hospital of the university. Dr. Ahmed AlHabash is going to talk about combining MicroPulse TLT with migs. This is such an interesting and a hot topic. With no further ado, I would like to leave the floor to Dr. AlHabash. Looking forward to this extremely interesting topic, Ahmed.
Okay, thank you, Ziad, and it's a pleasure to be with you all, guys. So I hope today we'll present something different and a new concept. So all of our, as you said, all of our glaucoma dream to have an early intervention with a very high safety profile. So that's what we are doing our best to do that. And this is mainly the different types of minimally invasive glaucoma surgery. You have the subconjunctival, something working on trabecular meshwork, suprachoroidal, and ciliary body. And how about if we try to combine these two pathways to work more on the trabecular meshwork and working on the ciliary body? And this study really inspired a lot of us when it was talking about the outcome of MicroPulse and good vision eye. So usually, and even my study, we usually did the MicroPulse in really advanced cases after failed surgeries and with high pressure, 30 and 40 and on full topical medication. So this when we try to reach the MicroPulse treatment. And this is the algorithm maybe that I'm using or others are using. We usually start with meds and then go to SLT or SLT then meds. And then we can go to the minimally invasive glaucoma surgery with cataract surgery. And after that, what we usually do, we go for trabs and tube and non-penetrating. But what if there is something in between the minimally invasive glaucoma surgery and the trab? So we are trying to delay as much as possible the conjunctival surgery. So the motivation of combining the MIGs with different mechanism of action is to try to achieve the lower IOP than individual MIGs that could usually accomplish. As we know that MIGs usually from our trials and from the randomized control trials, that it usually reduce the pressure between 20 to 30%. And maybe we can reduce also 1 or 2 bottles. So it's for a certain disease, for a certain category, mild to moderate glaucoma or something in between. But down to we are trying to go for a level that is down to comparable to trab and tube. So that's why when we are trying to combine these two mechanisms. And really, I tried to look a lot in the literature, and I didn't find a lot. I just find this study, which they combined the microtrabecular bypass, which is the iStent, with the ECP, with cataract extraction, and they found that combining the stent with an ECP, which is the endocyclic photocoagulation, had better results than only doing the stent alone. And I think Dr. Ahmed just mentioned in his previous presentation about this really nice figure. And in the beginning of our treatments, to be honest, we didn't know the best settings to go with. And usually in my paper that Ziad discussed that we had the advanced glaucoma or moderate to severe, we usually did a little bit, we were a little bit aggressive. So we needed a lower pressure. That's why we had a good success rate. But now with a good vision eyes, we can go a little bit lower with more safety margin. So what are the settings that we are using in combining the MicroPulse with with the minimally invasive glaucoma surgery, we usually do a 2000 milliwatt for 80 to 90 seconds for each hemisphere, which I usually go more in cases with more advanced disease. So I'll just go with 3 cases for the sake of the time quickly. This was a 72 years old female with multiple systemic disease, with advanced angle closure and cataract both eyes, as you can see, and hand motion both eyes, that was referred to me because she was not suitable for doing a surgery in an eye hospital, and I work in a general hospital. So the pressure is 30 on full topical and Diamox, and she's also on Pilo for like more than 20 years. So what was the decision? The patient can't lie down, and I discussed a lot with the anesthesia, and he told me that I'll give you a chance. I'll just give you one chance of general anesthesia, and you have like for 1 hour, 1 hour and a half maximum to do your surgery. So what I decided here is to go for phaco plus MicroPulse transclear therapy for both eyes under general anesthesia. And I'll just show you a quick surgery video of the surgery. We started doing the MicroPulse, as we said, for 90 seconds for each hemisphere, and then I prepped the eye as a usual cataract surgery case, and then we did the cataract surgery. It was a little bit difficult surgery because it was chronic synechia with the Pilo, so we had to use a mylugen ring. So you have to imagine, if I consider to do this patient for a phaco tube or phaco trap bilaterally, it would take at least 2 hours, 2 hours and a half for both eyes. On the other hand, we did this surgery for both eyes. It took like around 45 minutes. So it was a safe surgery. For the sake of time, I'll just go forward for the phaco because it's not our scope here. So we did a phaco. It was a dense cataract, so you might go into trouble in these cases. So that's why I elected to do a MicroPulse with the phaco. And after that, we implanted the IOL, and we had a good, for sure, I closed the wound with a suture. So postoperatively, I just saw her maybe before COVID. So it's 18-month post-op. The IOP is 17 and 18 on 3 medications. So we stopped the Diamox, we stopped the Pilo, and we stopped one of the prostaglandin. The vision is 0.3, 0.2. She's very happy with no complication, with the risk, as you know, with her age and medical condition. So the second case is a 70 years old female. She's the grandmother of one of my best friends. I did for her a phaco trap 6 months ago, and she had a leak because her conjunctiva was very thin. She's allergic to all types of medication. And then I had to resuture her, and we had a bit of a journey. And after that, she decided to go for the left eye because the pressure is 22, and she had and she had also cataracts with that. So I said, listen, we will try to go and do a MicroPulse with phaco and implant 2 stents. So we will try to have almost, or just beside the same thing that we did with trap, with less complication. And you can see this is the surgery of this patient. As she had a very thin conjunctiva, and you can see that while during doing the MicroPulse therapy, she started to have a subconjunctival hemorrhage because of this thin allergic conjunctiva. And then we did the cataract normally after prepping the patient, and I implanted the IOL, and we implanted 2 stents in the angle, and she was really happy. Regarding doing a phaco after MicroPulse, I did maybe now more than 30 or 40 cases, and it's safe. I didn't have any problems with the zonules or any other complications because of doing the MicroPulse before the phaco. So I think it's a really a safe procedure. So postoperatively, 9 months now. Her vision is 20/20. IOP is 13. On one medication, she's on tafloprost, which is cephalotan, which is a preservative-free, because this is the only medication that she can tolerate. And she's very happy, and she's doing better than the eye that we did the phaco trap. The last case, this case is a little bit different and interesting. She's a 39 years old hyperopic female that had an acute angle closure glaucoma in the right eye, and she had a surgical PI after 2 failed attempts of YAG PI in another hospital. And she was referred to me after a week of that, and her pressure was still 51. Her cup disc is fine, 0.5, 0.3, and she had a closed zipped up angle. So what I decided to do for this patient is to do a phaco plus IOL plus a hook dual blade and syneculitis and a MicroPulse transcatheter laser therapy. The other hospital, they offered her a trap. So I think trap and angle closure might go into trouble. So that's why I decided to do this procedure. As you can see, she has a very shallow anterior chamber and an anterior segment OCT. You can see the synechia and the angle. So, and maybe she had a bit of type of plateau. So we decided to go for a MicroPulse, as you can see. A MicroPulse, and removing her lens and going for this is a routine cataract surgery. After implanting the IOL, we did the gonioscopy, we did a little bit of syneculitis, and we tried to do a goniotomy and goniectomy to remove the trabecular meshwork and cleaning it up and viscodilate a little bit of the canal. So working on these both entities saved it a lot and had a really good results postoperatively, and you can see a nice cleft after doing this procedure. So postoperatively now, it's 1 year. Her vision is 20/20. Her pressure is 12 without medication. Her visual field and OCT is stable, and she's very happy. And we didn't need to go for any complications. So as you can see, this is the postoperatively. You can see her surgical PI, her old surgical PI that she did. Her eye is quiet, AC is fine, IOL place, and she is happy. And this is her anterior segment OCT. Although she had some areas of still peripheral synechia, but you still have this nice cleft that it correlates in the gonioscopic appearance, and she is fine. So I would like to thank everybody, and if anyone have a question, I would like to answer that. Thank you.
Thank you, Ahmed, for this amazing presentation and the wonderful videos. It's really interesting how you're combining different procedure with different mechanisms to achieve the best outcomes for your patients. So my questions here is, when you're combining phaco to MicroPulse, are you noticing any increase in inflammation or cystoid macular edema post-op in the patient where you're combining both procedures?
To be honest, I didn't have any macular edema. You might encounter macular edemas, but in my cases, I didn't have. There's a little bit more inflammation than when you do a regular MicroPulse on a phakic eye, or just a MicroPulse on pseudophakic. So that's why I usually hit them hard with steroids like every 2 hours and taper them slowly. But I didn't have any refractory inflammation, so it went with time.
Cool. Any of the other panelists is combining phaco to MicroPulse? Anyone has experience with it?
No.
Yeah.
No,
Yes, for sure. I did.
So
I don't find any increased inflammation apart from the usual in most in all my fecal cases. And as Dr. Ahmed saw us, as Dr. Ahmed presented, the technique is so simple that you can do it before you go for fecal. I advocate, of course, to do it before you do any incision in the cornea, because you have to apply some pressure. So it has to be done before you go for the fecal procedure.
So we have a question here on the chat saying that if this technology is safe, why not to use it instead of MIGs? Well, Ahmed AlHabash has shown that you can combine it with MIGs in certain cases. So Ahmed, I'm going to ask you, what would be the ideal patient where you would go for a combined procedure? Are we talking about early glaucoma, moderate glaucoma, or are you even doing that in advanced cases?
I think the spectrum is large, but I usually keep it to the moderate to severe, or I think that in my algorithm that you need to go for a subconjunctival surgery. So I leave it for that area. So if it's mild to moderate, I might just do a MIGS. But it's a different story because I'm going for cataract surgery, so we don't want to mix up things.
Okay. So the last question to you, Ahmed, is from our friend, Dr. Karim Tame in Beirut. How much does the efficacy or the intent of the MIGs really add to the procedure? So what's working? Is it the MicroPulse? Is it your phaco? Is it your syneculitis? It's difficult to say what's working. So what are you really adding by doing the MicroPulse?
Yeah, I was expecting this question because it's going to be a little bit confusing, which is working in this case. To be honest, you are hitting different mechanisms. Okay, so as we know that the regular eye stent can go for 20 to 30% reduction. If doing a syneculitis or goniotomy, you might have a little bit more. And with a MicroPulse, you can increase the UV scalar outflow and decrease a little bit the production. It's really a tricky question, to be honest, to say that it's mainly from the MicroPulse or the eye stent, but I think the MicroPulse has an upper hand of decreasing the pressure more than the other MIGs and help us more. But as we know that the MicroPulse might need another setting, so it might delay things with putting MIGS procedure over there.
Okay, so this also answers a question that we just got from Hussein Ogla. How long does the effect last?
I think no one knows about that. So some of the cases are doing fine for 1 year or 2 years until now, and we didn't need to augment them. Some needed to be augmented after like 6 months. So it depends. It depends, and this is the word that we usually use in glaucoma. Depends on the case.
Exactly, and this is also one of the advantages of this technology, is that it's a repeatable procedure in most of the cases where you need to do it again. So thanks again, Dr. Ahmed AlHabash, for this great presentation and those insightful comments. And it's my pleasure to introduce our next speaker, Dr. Awada. She's a major figure in the glaucoma field in the Middle East. She's the chair of the glaucoma division at the King Khalid Eye Specialist Hospital in Riyadh, Saudi Arabia. She's the member of the glaucoma editorial board of iWiki and an ex-member of the board of directors of the Saudi Ophthalmology Society. Dr. Awada is going to talk about challenging cases with MicroPulse TLT. Dr. Ahoud?
Thank you so much, Dr. Ziad, and thanks to all the organizers from Iridex for giving me this opportunity. So before I start my presentation, I just like to mention a few words about King Khalid Specialist Hospital, or what we used to call it KCASH, the hospital where I'm working and happy with. KCASH is the largest ophthalmic tertiary referral center in the region, and with more than 240 beds and more than 13 operating theaters, we consider ourselves to be the center of excellence for tertiary eye care. So with that being said, we only receive and deal with the most complicated cases, with the difficult cases. The MicroPulse machine has introduced officially to our department on 9th of September last year. So this is very memorable date, 9/9/19. And since that date till April, more than 260 cases were done, and almost about 30 cases were under my care. Now, let me just spend a few minutes on this slide. Here are few of those cases or the challenging cases that I did. And I want you to look to the diagnosis here and the pressure, starting pressure, or preoperatively and postoperatively. And basically, to start with, none of those patients had the MicroPulse as a primary procedure. All these patients had multiple previous surgeries, and the MicroPulse was done after those procedures. Almost all of them, except for the children, they were on maximum medical therapy, including the Diamox. So look to this case. This is an 8-year-old boy with a Sturge-Weber syndrome. Starting pressure was 45, and he ended up with 26 millimeter mercury, IOP. It's almost around 50% reduction of the IOP, and even his vision improved from 2300 to 2125. Primary congenital glaucoma, also, they got excellent results. Primary open angle glaucoma with poor vision, starting pressure of 46, ended up with 17. Again, another case of primary congenital glaucoma. Look to the pressure. A primary congenital glaucoma with secondary or with PKP, pressure 35, ended up with 25. This one also, a patient who is having a light perception, starting pressure of 27, ended up with 12, and he's only on 2 topical medications. Another case of glaucoma with trauma and secondary glaucoma. Also, patient had PKP, starting pressure 19, and after the laser it was 12, with also improvement in the vision. MVG, we do a lot of cases of MVG, and we face and encounter a lot of those cases in King Khalid Specialist Hospital. Pressure before the MicroPulse was 36, ended up with 23. Another lady, she's 32 years. She's a case of Best disease. I remember her. She's a case of angle closure, and I did both eyes. Starting pressure was 28 and 22, ended with 14 and 10, and she's only on 2 topical medications. She's very happy, even the vision was improved. Another case of primary congenital glaucoma, starting pressure 35, ended with 12. A case of silicone oil with secondary open angle glaucoma. Again, pressure was 26, ended up with 11 with 2 topical medications. Pseudoexfoliation, pressure was 41, ended with 15, with stable vision on 3 topical medications. So all those patients, we stopped the Diamox. They didn't have any serious complications. But actually, this is not the case. This is not the life all the time. Every now and then you should have a case that gives you a nightmare. So this is a case that I would like to share with you. He developed very rare, uncommon complication. He's a 47-year-old gentleman, known case of Marfan syndrome with an ACIOL and dislocated crystalline lens in both eyes, as you can see here in the B scan. diagnosed as a secondary pseudophakic glaucoma, and he was put on full topical medication in both eyes. His visual acuity was 20/30 both eyes, pressure 23 and 26 in the right and left eye respectively, clear corneas, deep ACs, stable in place AC IOLs in both eyes, cup disc ratio 0.5 and 0.8, and he showed some progression in the visual field in both eyes. So based on those informations, because of the progression in the visual field, because of the uncontrolled IOP, and because the patient wanted to be, cut off some of those topical medications. So the plan or the decision was to go for MicroPulse TLT in both eyes under local anesthesia. The procedure was done in both eyes. One eye was done by my fellow and the other eye by a senior resident under my complete supervision. The laser settings, of course, the power was 2000, it's constant, and the duty cycle is 31.33%. The duration, we did 90 seconds per each hemisphere, so we did a total of 180 seconds, and the movement was done for each hemisphere with 5 passes. Now the passes, or the number of passes, identify how fast you are with the probe. So ideally it should be 5 passes per each hemisphere. The procedure went uneventful, very smooth. Nothing happened during the operation, and the patient was put on intensive prednisolone acetate to taper over 6 weeks, atropine, antibiotic, and he was kept on all his topical glaucoma drops. Now, the next day after the laser, the vision dropped to 20/200 in the right eye and hand motion in the left eye, and that was a big shock for me and for the patient. Pressure was okay. You see, the pressure was 19 and 16, still on the anti-glaucoma medications, and he had a painless corneal epithelial defect in the right eye, some corneal edema in the left eye, severe inflammation, AC was still deep, a B scan was unremarkable, so we decided to increase the topical steroid. We brought him 3 days later. He showed a very evident corneal epithelial defects in both eyes with choroidal detachment, as you can see here in the B scan, both eyes. So we decided to admit him. We stopped the steroid and we started him on topical fortified antibiotics, of course, with the atropine and the excessive lubrication. After a few days, or by the end of the first week, his corneal epithelial defect was improved slightly in the left eye. Inflammation also was improved. The corneal culture came to be negative, so we decided to discontinue the fortified antibiotics. And at that stage, we had to consult our colleagues from the corneal department, whom they advised to start the patient on medroxyprogesterone acetate, which is a hormonal reagent and anti-inflammatory, and can promote the collagen synthesis. He was also put on serum, BSS, and bandage contact lens was applied in both eyes. Now, by the end of the first month, there was a mild improvement of the corneal epithelial defect in the right eye, almost complete healing in the left eye. So the patient was offered an amniotic membrane transplant on the right eye, which he refused because he thought he might, the right eye might improve the same like the left eye. So he refused the amniotic membrane. So the cornea team decided to start him on serum endorit-rich plasma growth factor for the right eye. 1 month later, or actually this is the last time we saw the patient, his best corrected visual acuity in the right eye was 20/200 in the right eye, 20/70 in the left eye. Now look to the pressure. Pressure was 16 and 10, and the patient was off all the drops because we stopped all the medications once the choroidal detachment was evident on the B scan. So now the patient has excellent IOP without any medications. I mean without any anti-glaucoma medications. The epithelial defect mildly improved in the right eye with some stromal opacity, but unfortunately the patient still refusing any further surgical intervention. Choroidal detachments improved completely from the fundus. So till the time of the preparation of this presentation, I could only put my hands on 3 papers published talking about neurotrophic corneal defects or ulcers after dyed laser cycloablation. The first paper was published long time ago on 1998, and it was talking about the neurotrophic ulcers in dyed laser cycloablation and the cyclophotocoagulation, the regular or the conventional one. And they concluded that the patient should have risk factors like diabetes or chronic inflammation or other conditions that can predispose to this type of complication. The other paper was published on 2016 at one of the Spanish journals. And it also concluded the correlation of high myopia, and it discussed how patients with high myopia could have more risk for developing this type of complication. The only paper which mentioned the neurotrophic keratitis after MicroPulse TLT was published last September in 2019, and it also discussed some of those risk factors that I'm gonna speak in the next slide. So to have such a complication, which is neurotrophic ulcer, you should have either some risk factors or thermal damage. The risk factors include diabetes, chronic inflammation, herpes keratitis, corneal dystrophies, history of previous ocular surgeries with large incisions, use of adjunctive mitomycin C, and none of these risk factors, they were evident in our patient. High myopia and chronic use of topical beta blockers. Actually, our patient is a Marfan syndrome. He's myope, and those patients with high myopia, especially if it is axial myopia, they have stretched and thin sclera, so they have that risk of having more thermal damage and developing such a complication. And definitely he was on long-term use of topical beta blockers. The other etiology for having such a complication is the thermal damage, which can result on the long serially nerve. So that's why the recommendation of not to applying the laser on the 3 and 9 o'clock position. The other theory is about the ablation of the perilimbal nerve plexus, and this can happen if the probe is a little bit more anterior. And the last theory is having an over-treatment, and we didn't have that in our patient. Actually, we respected or we followed the operational instruction given by the company, so there was no over-treatment. So this is my last slide. What are the recommendations to avoid such a complication? You should discuss with the patient. Even if it is a laser procedure, if it is very safe, it's not a complication-free. So you should sit with the patient, you should discuss with him that there are some anticipated complications might happen, especially if he's having some of those risk factors. Corneal sensations, it might be worthy to check those, the corneal sensations in those patients with high risk. And I would recommend, and this will be my routine, I will check corneal sensations in each patient going for MicroPulse. Having less laser parameters, again, this is a question, there is a question mark here. Shall we go less with the power or shall we go less with the duration? It depends on the which machine we are using. It's very important that we monitor the patient closely and try to tackle those complications very early before the patient gets more, more complications and more sequelae. And the last point discussed or mentioned in one of those papers published is the use of confocal microscopy which can show the corneal nerves. But to be honest, all the studies, all the published studies didn't show any difference between the normal control group and the patient with Marfan syndrome in terms of corneal nerves. So that was not the situation with our patient. This is all what I have today. I would like to thank you all, and I would like to thank my fellow, Dr. Nofa Zindi, for providing me with some of the data. Thank you so much.
Thanks a lot, Dr. Awada, for this interesting presentation and this this case that you presented. I just wanted to ask you, you were mentioning some cases with neovascular glaucoma in the table that you presented at the beginning of your talk. How would you describe your results in neovascular patients using MicroPulse? What's your experience?
In terms of IOP reduction, the results was very encouraging, but those patients, I have noticed that those patients and the patients with uveitis, they might have more inflammation after the laser. So you should, hit them maybe even before the laser with a good course of steroid, and you should follow them more closely.
I absolutely agree. Usually those eyes, like uveitic eyes, neovascular eyes with neovascular glaucoma are really sick eyes, and you really don't know how they're going to react after any type of surgery or any type of laser treatment. And they are usually at high risk of hypotony or phthisis. So one should be quite careful with those eyes. And as you are saying, like preparing yourself, discussing the risk with the patient, hitting them hard with steroids and all those types of procedures. So we have a question here. Given the risk of neurotrophic cornea with MicroPulse, Dr. Awada, would you change the type of application or the power? What would be the parameter that you would change, the power or the time of treatment?
Well, the power is always constant in the machines that we are using right now. We are waiting for the next version of the new machine at which you can change the power, but the power is constant. You can play with the duration, but for my side, I want to go with a different protocol. I will follow the same protocol, but I will give more time to investigate and to see if this patient is liable to have those risk factors or those complications or not.
Okay, so when it comes to parameters, because we had a lot of questions in the Q&A about the parameters, you have two options basically when it comes to MicroPulse. You can either play a bit with the power, so the recommended setting is 2000 milliwatts. You can increase that or decrease that. There is a very interesting paper in ophthalmology glaucoma that was published a couple of months ago by Nathan Ratcliffe in New York. So he basically divided his patient in subgroups depending on visual acuity. He used the same treatment times in all eyes, which is 50 seconds per hemisphere, and he titrated the power of the laser depending on visual acuity. So eyes with good visual acuity, he treated them with low power, and eyes with bad visual acuity, poor visual potential, he went up with the laser power. So that's an option. Another option is, instead of playing around with the power of your laser, you can titrate the time. So we've seen in the literature, people using 50 seconds per hemisphere or even up to 150 seconds per hemisphere. So we still don't know what the ideal parameters are, and this is why there's a huge interest in MicroPulse, and a lot of papers are going out, and I'm sure that we will have also other ideas now being published with the new probe. So my question here is for the rest of the panel also, because we had two questions in the Q&A about that. Some of our friends here in the Q&A, Ahmed Hosni, Hussein Ogla, have been using subconj dexamethasone at the end of the session. Any of you guys have been using subconj DEXA at the end of the MicroPulse session to fight inflammation or prevent inflammation?
Yes, yes, Ziad. I usually give them all subconj DEXA at the end of the surgery. All the patients usually.
And it's my routine as well. It's my routine to give subconj. Yep.
And sometimes if we have, like, as you said, these new vasculars or something, I usually give them subtenon's Kenalog injection.
And are you giving NSAIDs and steroids post-op or just steroids topical?
Mainly steroids. You know that steroids usually cover both. If you're going to go with Pret 40, especially with our eyes are maybe a little bit different than the light iris, so they have a lot of inflammation post-op. So I think hit them hard with steroids. Pret 40, prednisolone acetate 1%. I think it's more appropriate than even give them like the weaker steroids like Lotimax and different things.
Yeah, I remember
only
back.
Give steroids.
Yeah. Only steroids.
So,
only steroids, Dr. Awada?
Yeah, but I go more with the duration, so I taper it on a longer period.
Yeah. Well, back when I started in 2016, we used to give atropine, steroids, and NSAIDs. So we were quite aggressive post-op. But then with time, when we had more experience with the technology and we noticed that the inflammation was really minimal in most of the uncomplicated cases, we stuck to steroids only for long duration, as Dr. Awada was mentioning. So thanks again, Dr. Awada, for this great talk. It's my pleasure now to introduce our fourth speaker tonight. So last but not least, it's Dr. Walid Zbiba. He's a VR surgeon and a professor at the Faculty of Medicine in Tunis. He's also the head of the ophthalmology department in Nabil. Dr. Walid Zbiba is going to talk about MicroPulse TLT in glaucoma secondary to silicon oil. Walid, I leave the floor to you.
Okay. Okay. So good evening, everybody. Thank you for inviting me to this webinar. I'm pleased to share with you our experience about MicroPulse laser therapy in silicon oil-induced glaucoma. So as we know, silicon oil was first introduced in 1960 for intraocular component in vitreoretinal surgery. It may be used in different complicated cases of retinal detachment, such as RD with the marked PVR, traumatic cases, or fractional cases, or RD in viral cases of retinal detachment. So, despite silicon advantages, it can be responsible of various complications such as intraocular hypertension that may be early or intermediate or delayed, moderate and transit, or severe and sustained that may cause a loss of vision. So in our study, we are interested in intermediate or late intraocular hypertension. This may be caused by infiltration of trabecular network by silicon buds, and also with chronic inflammation, cynical angle closure, plunge tamponade, idiopathic open glaucoma, and steroid-induced glaucoma. So different ways are available to manage this kind of pathology. Medical treatment may be first used with high risk of incision treatment. Then we can use silicone oil removal, may be useful in early cases, but studies show that in late cases, the removal of silicone oil is not effective. Then we can use the glaucoma drainage devices The problem with this kind of devices is that silicon particle may be migrate into tube and valve and block it, the aqueous humor drainage. We can also treat with trabeculotomy. This kind of surgery is known to be difficult in in eyes with vitrectomized eyes with a high risk of failure. And finally, we can treat this kind of pathology with cyclodissection procedure may be useful, such as conventional continuous laser photocoagulation, but it can lead to high risk complications such as lost vision. So we need an alternative is needed. And for that, we suggest to use MicroPulse laser therapy. How does it work in cases of silicon oil induced? First of all, like we have seen before with Dr. Ziad, MicroPulse is responsible of decrease of aqueous humorous inflow with no atrophy, and it enhances uvascular and trabecular outflow with different mechanisms demonstrated by Dr. Ziad. Additionally, we speculate that the essence of vitreous gel may be facilitate in posterior and inward movement of cellular body in case, and it's more increase the uval, the outflow of humor aqueous through the uvascular tissue. So let's move to our study. We treated a patient using glaucoma laser system, cyclogesis, and the classic MP3 probe Rev1 with a power 2000 milliwatt with a data cycle 31.3%. And we use 80 seconds per each hemisphere. We included 33 patients with a majority of men with a mean age of 50 years old. So silicon oil topinol was indicated for rhegmatogenous retinal detachment in 70% of cases, and for tractional retinal detachment in 30% of cases. Silicon oil removed before treatment for the majority of patients. Only 7 patients had persistent silicon oil tamponade. Concerning IOP evolution, at the inclusion, IOP was about 40 millimeter of mercury, which is higher than the usual observed figure in primary open glaucoma. Since day 1, the IOP started lowering with the maximal efficiency the first week. Then the IOP remained stable for 6 months, reaches 47%. Concerning treatment tapering, we need to explain that the mean treatment number decreased from 3.8 to 2.9, with 30% of patients were under oral Gamox treatment. And at the 6-month follow-up, half of the patients stopped oral treatment. As the success criteria, we considered either the 20% decrease of IOP or the treatment tapering. In our study, the success rate was over 90%, with two following cases. The first one had a history of congenital cataracts and microcornea, a phakic eye, and multi-operated eye. The second case is had a multi-operated eye for recurrent retinal detachment. The retreatment rate was 12%, and we retreated patient for treatment failure or for IOP target wasn't reached. During the study, we were thinking where we can treat or not patient before silicone eye remove. And the answer is yes. We can treat this kind of, and with the silicone in place. So actually, patients were divided in two groups. The first group of patients which treatment was done after silicone eye removal, and the second group which treatment was done before silicone removal for different reasons. In conclusion, we found that there is no difference between the two groups. Side effects observed were hyperemia, which is the first observed side effect. Anterior chamber reaction frequency absent. In 70%, it was absent, this kind of side effect. And mild post-operative pain. There is no case of disease or prolonged inflammation. We are going now to report two cases. The first one is a man 50 years old with a history of vitrectomy and silicone oil component for complicated diabetic retinopathy. A silicone oil-induced glaucoma treated initially by medical treatment and valve of Ahmed, but the IOP still no control. After MicroPulse TLT, the pressure was within normal limits, and the patient was able to stop gammas. The second case is a 70 years old man with a history of vitrectomy with a silicone oil component for rhegmatogenous retinal detachment, complicated with glaucoma. And in this patient, with silicone still in the eye, we can't remove the silicone because it's a complicated case. So the IOP was no control, but after MicroPulse TLT, the IOP reached 16 millimeter of mercury without oral treatment. In conclusion, silicone oil-induced glaucoma is a serious and challenging complication of silicone oil tamponade. It can be responsible of high fluctuation of IOP levels. Early and effective treatment is needed. MicroPulse TLT is efficient and safe treatment method. It may be useful even before silicone oil removal. Efficiency may be compromised in multi-operated eyes, and other predictive factors should be studied in the future. Thank you.
Thank you so much, Walid, for this interesting talk. We all know that silicone oil-induced glaucoma is a very challenging subtype of glaucoma. So my question here for the panelists, in such cases, what would be your first line of treatment? Let's say in a patient who has a history of, retinal detachment, silicone oil. The silicone oil has been removed, but you still have a little bit of, emulsified silicone oil in the angle when you examine the patient by gonioscopy. What would be your first line of treatment? Would you go for a tube? Would you go for subconjunctival, classical incisional glaucoma surgery, or would you go for a MicroPulse type of treatment?
Or before?
Yeah.
Okay, Dr. Ahmed, go on.
Okay, so regarding these cases, usually it's good to have retina on our side this time. Usually we have a lot of talk to convince them to remove the whole silicone oil, but you know that you can't remove the whole silicone oil. So I did a couple of cases of the MicroPulse and silicone oil. Some of them worked, some of them didn't work that much. It depends on the eye itself. If it has a good vision potential, I would go for an inferior tube. And it depends on the vision. I don't know if anyone has it.
What about you, Dr. Abdelmajid?
Okay, we all know that silicone oil-induced glaucoma is considered as a refractory type of glaucoma. Before the introduction of the MicroPulse TLT, I usually use the medications to control the IOP, and by the end, if it fails, we have to go for the tubes or shunts. But now I think it's a good option, but I can see that we may need more than one session to control of IOP in such situations, because there is, I think in silicone oil induced, we have some irreversible damage happened to the trabecular meshwork.
Thank you, Dr. Abdelmajid. What about you, Dr. Awada? Because I know you guys have a big and active VR department at King Khalid. So I'm sure you have a lot of those patients coming in the glaucoma department. What's your first line of treatment? Would you go for an inferior tube as Dr. AlHabash was suggesting?
Well, as Dr. AlHabash mentioned, it's always difficult to convince our retina colleagues to come and remove everything. And, you know, I don't blame them, because it's really difficult to remove all the silicone. But in the old era, I used to go for a tube. I didn't use the conventional cyclophotocoagulation. It's not on top of my list to go with the silicone oil induced glaucoma, because it can give an irreversible, you know, hypotony. Once you do it and the pressure goes down and the patient goes into hypotony, he can go into phthisis bulbi. You cannot treat that. But with the tube, it is reversible. You can do something for it. Now, the only case that I did with the MicroPulse, the results were very excellent. So I think it's one of the options that we can consider in those situations.
I totally agree. And one should be very careful in eyes that already have, you know, that still have silicone oil inside, because, you know, once you do your MicroPulse or any type of cyclophotocoagulation in those eyes, if the silicone is removed, you know, after a year or 2 years, your VR surgeon might run into problems, hypotony or phthisis or any type of those complications. So you should always try to treat those eyes safely, because you cannot take back basically the effect of your procedure. I'm just going to ask a couple of questions before wrapping up the session, you know, practical questions that could be interesting for our audience, and I would like to have the input of all our panelists. So, what's
Dr.
your
Ziad, can I add something? Yeah, can I add something just in the same scope? We should be very careful. Yeah, with patients and with silicone oil, we should be very careful with the positioning of the probe, because you might have leak from some areas, because those you know, eyes are weak eyes with weak conjunctiva. They might have thin sclera because of the previous retinal surgeries. So you should be very careful with the positioning of the probe, because you might have leaking of some areas, leaking of the silicone.
Yeah, always. This is a very good tip from Dr. Awada. Always try to avoid any area of scleral thinning. You should avoid the area of the bleb if the patient already had a trabeculectomy or any type of, you know, filtering procedure, and you should also try to avoid the area of the tube. So it's not always possible to treat 360. You should always avoid any area that looks a bit fishy to you. So I just wanted to ask you guys, what is your go-to or your favorite type of anesthesia for your MicroPulse patient? Do you go for a block? Do you go for for a GA? Do you go for a flash sedation? What do you guys do in your different centers?
I go for the, yes, I may start. Okay, for me, I go for the peribulbar. I think it is more safer than the retrobulbar. And I prefer to do it in the OR because we all know whenever you inject the local anesthesia, you may have some spread along the brain stem cheese, and you may have devastating complaints that you cannot manage at the office. So I like to do it in the OR and of course in the presence of anesthesiologist. This is more safe for the patients. And sometimes if the patient is not cooperative at all, we can turn it into general anesthesia.
What about you, Dr. Awada?
I prefer the local anesthesia unless the patient has other, indications to go for a GA, then that's fine. But I usually go first with the local.
And do you do it in the OR or do you
OR,
do it in the?
Yes.
In the OR.
This is our protocol. We do it in OR. But it can be done in the outpatient. If you have a good setting, if you have a good anesthetist nearby, then it can be done in the clinics.
What about you, Ahmed?
Well, I usually do it as an peribulbar, but I did a couple of cases with a good sedation and just lidocaine gel, especially with these patients that are risk of having bleeding. They are on blood thinners and you can't stop them. So if you give them good IV sedation with your anesthetic, I think it can be done with putting a lidocaine gel or just injecting subconjunctiva a little bit.
What about you, Khalid? Do you always go for?
So I usually do it in OR with local anesthesia. Usually with local anesthesia.
Okay. You know what?
And
one thing
I don't use subconjunctival Dexamex.
Dexamethasone.
After, yes.
Just to come back to your comment, Ahmed, concerning a GA with lidocaine jelly. The problem with doing that is post-op pain. Sometimes because the good thing about the block is that it also covers all the post-op pain, which is something that you cannot get with the lidocaine jelly. And this is what our experience is, so far. So either under GA, we would give, a little bit of either subtenon or subconj anesthesia just to deal with the post-op pain.
I have a question, Ziad. I don't know if someone of the panelists noticed that if you have patients with pressure of 40 and 50, and when you do a block on them and you start giving them the treatment, they feel they're more irritant to pain than others. I don't know if you notice that, especially in these neovascular glaucomas. Even if you give them a good block, they still, because of the high pressure preoperatively.
I've never had such a problem. What about you guys?
I don't think so. It is about the pressure. Some patients may have low threshold to pain. And I think this may need to add some sedation and even go for general anesthesia because actually the procedure is painful.
So we have here two questions from Dr. Ahmed Hosni. The first one is about comparison of effectiveness of IOP reduction and post-op inflammation between ECP and MicroPulse when combined with fecal. I think this is something that Dr. AlHabash should answer. So what's the difference between ECP and MicroPulse, Ahmed?
Well, I think Dr. Ahoud also knows that more. I used to do a lot of ECPs before, even for open angle combined with fecal. But now I start to reduce this indication to only closed angle and only plateau iris. I think the inflammation, I noticed a little bit less in the MicroPulse than the ECP. I'm not sure why, but that's what I noticed. I think we need more prospective randomized trial to compare ECP with the MicroPulse. I don't know, Dr. Ahmed, what do you think?
I think we're just comparing apples to oranges because different. Yeah. Yes. Can you hear me?
Yeah, we hear you now.
Yeah. Yeah, we are like comparing apple to orange. If you compare between the ECP and the MicroPulse, they are both laser, but they have different, modality, different mode of action, and different application. I agree with Dr. AlHabash. The MicroPulse showed less inflammation, but again, I think both of them, they have different indications for the patients.
So I would like to thank all the panelists for their great input, their great presentation too. Unfortunately, time's up. It's been an hour and a half. So I would like to conclude this this webinar. It was very interesting. We learned a lot, and it shows that there's a growing interest in this technology, and hopefully with time there will be more publication, more peer-reviewed literature, and we'll know more about the safety profile and the efficacy of this technology. So thanks again, everyone. Thanks also to all the attendings who've been with us since the beginning of this webinar, and I hope to see you soon. Bye-bye.